So I'm just going to say welcome. Thanks for coming. My name is Marcia Balzer. I'm the CEO of the Australasian Sleep Association, and it's great to have you with us today. I want to say a special thank you to our speakers from Medicare and from the Department of Health and Aged Care who have worked with us on this webinar, and it's great to have you with us. I'm going to start with by acknowledging the traditional custodians of the lands where we live, work and sleep, the Aboriginal and Torres Strait Islanders of Australia and Māori as Tangata Whenua, people of the land of Aotearoa. And the context for this webinar is the new explanatory note to the sleep study items that was released last year. There was a little bit of confusion that came out of that, and the Department of Health policy people said, "Is there anything we can do to help with some of those questions?" And we said, "Yes, there is. You can run a webinar for us." Actually, I think they might have suggested it rather than a suggestion coming from us. So that's why we're here today. Just the webinar is being recorded and it will be available to you on the ASA Learning Centre, and I will send you an email when that is available for you to look at again if you would like to do that. We have got a fairly long presentation, and so hopefully there will be some, which includes answers to some of the questions that have been asked in the lead up to tonight's webinar. If you have additional questions, you can ask them in the Q&A box, which you should see on your toolbar. You might have to click the little 3 buttons that say more to see the Q&A. And if there's time, we will try to, our presenters, I won't be answering any questions, we'll try to answer your questions. Please be aware that we don't want to give wrong information, so there may well be, for some spontaneous questions, the answer may well be the department, and we will work on it for you and get back to you, rather than try and make something up at the time or articulate something that may not be 100% accurate. So please just be patient if that's the answer to your question, and we will follow up and make sure that questions are answered where possible. I'm going to hand over to David Cunnington, who is going to chair today's session, and then I'm going to jump off and run the PowerPoint. David is the chair of our clinical committee and also on the ASA board, and has been very much involved in, everything clinical that the ASA does, really, including communication with the Department of Health around these types of issues. So David is a sleep and respiratory physician from the Sunshine Coast in Queensland, formerly from Melbourne in Victoria. I think that's all I have to say. I'll hand over to you, David. Thanks very much.
Yeah, thanks very much, Marcia, for that introduction. And again, thank you to our presenters for this evening, Steve Dunlop and Dr. Kris Kandasamy, and we'll hear from you shortly. As Marcia said, the context for this was in seeking some feedback after the explanatory note was published July 1st. Some of what was apparent was the questions were not only about the specific things around sleep studies and around sleep study diagnostic item numbers, but a lot of the questions actually, when we looked at it, demonstrated maybe a lack of understanding of some of the fundamentals of Medicare and the Medicare system. And so that's part of what will be covered tonight. So as we go through the presentations, you'll see some of the answers are specific to the sleep diagnostic item numbers, whereas some of the discussion is a bit more of just that underpinning principles of the Medicare system, which we don't get trained in medical practice and almost expected to have an assumed knowledge of it. And sometimes it's those underpinning principles that actually answer our questions. And we get too far in the weeds looking for the really minutiae in the specifics, but we've actually lost track of the fact that the fundamental principle would have given us the answer in the first place. So with that, I'd like to introduce the first of our speakers, so Mr. Steve Dunlop, and Steve's the Director of Medical Specialist Services. So thank you very much, Steve.
Thanks very much, David. Look, and just to echo the commentary that was just given as the introduction, Today, for us, it's providing a bit of an overview about the different areas of certainly our department that are involved in a range of MBS items, whereas Kris's area looks after the benefit and integrity side of Medicare. It's my team that is largely responsible for the policy that underpins and also the items, both in terms of how they operate and the crafting of the MBS item descriptors. From a department point of view, we're committed to ongoing dialogue and discussion with the ASA. We're open to these sorts of forums, not just as a one-off, but on an ongoing basis, and also for ongoing discussion. So please don't feel that this is the only opportunity that you'll ever have to talk through these issues with us. There's ways of reaching us, which we include in our presentation, and we're open to having discussions to try and help the sector understand and underpin the appropriate claiming of any MBS items. So, sorry, I'm going to have to be saying next slide as we go because of the way we're running this. But Marcia, if you want to pop off to the next one. Yep, so that's me. I've just done my introduction. I'll skip through. There we go. So I work, as I mentioned, in the policy side. We sit within what's called the Medical Benefits and Digital Health Division within the department. And it's this division that has overarching policy responsibility for all MBS items, both across those delivered by primary care as well as those delivered by specialists or consultant physicians. That can include attendance items, surgical items such as general surgery and orthopedics, gynecology and obstetrics, and of course sleep study items across the MBS. Briefly, within the branch in which I sit, we're responsible for Medicare programs and hold responsibility for working with Services Australia in areas such as Medicare eligibility, policy programs such as the extended Medicare safety net and safety nets, medical treatment overseas, as well as medical indemnity arrangements. We also work with other areas within the department, such as public hospitals and private health insurance, and other broader policy areas across the department, such as women's health. Currently, we're supporting the work of the Medical Services Advisory Committee on a range of applications across my sphere of influence, one of which is relevant to sleep, is an application that relates to unattended paediatric sleep studies, of which the ASA is involved, as well as a planned post-implementation review, or PIR, of changes that were made by the MBS Review Task Force with relation to thoracic medicine. We would expect that review will kick off later this year, and will be a valuable opportunity to discuss the changes from the MBS Review Task Force, any unintended consequences and issues that might lead to subsequent changes of items, noting that that's a consultation process that happens with the sector. As mentioned, we're happy to run through questions provided in advance of the meeting. We'll include those to the extent within this presentation. But as Marcia mentioned, we're happy to take questions on notice at the end of the presentation if we can't answer them for you today. And we'll provide some helpful contacts if you want clarification on any other issues that are raised. So following to the next slide. I'm sure I'm preaching to the converted, but I won't linger on it too much. But obviously, there are a range of items that we have sitting within, I guess, two broad categories. This is the adult category of items. This slide outlines the current MBS items relating to adult sleep study. That includes 2 diagnostic sleep study items, including both laboratory and unattended sleep studies, as well as items which provide for initiation, effectiveness, and subsequent investigation items. Notably, these items include frequency requirements, which reflect clinical practices determined by the profession. And in total, there are these 6 items. The most wide ones being used are, of course, items 12203 and 12250, which are the diagnostic items. So this is just a bit of picture of what we receive in terms of MBS data. It's important to note at the outset, this is aggregate national information. So we accept that there are variances that occur across each jurisdiction, state and territory. The MBS is not the complete picture. We only capture those services for which an MBS claim is made. So we don't get information about things that occur outside of MBS arrangements, be them either within private or within public settings. At the time, you can see in here that what we've seen over the recent years is a few interesting trends. So you can see that there's been a significant increase. The red line is home-based or unattended sleep studies, and that's been significantly climbing since it was introduced in 2008-09. And you can see that concurrently there's been a drop-off in lab studies, which we would probably expect as people shift towards the more unattended sleep studies being the preference, which would reflect both access for patients, preferences for patients, and also the safety and quality of the provision of those services. In here, interestingly, we've included just a few milestones. So you can see we've marked when the interim item was first introduced. At the time, MSAC was uncertain about the likely take-up of level 2 testing, but we did expect that the availability of home sleep studies would reduce the volume of lab sleep studies, and that seems to be consistent with what's occurred. And of course, over time, the use of 12250 has indeed overtaken 12203. So as I said, we've seen a steady increase. It did increase at a bit of a lower rate until 2017-18, and then shows an abrupt drop in usage. That, to an extent, seems to correlate with changes to the ASA guidelines and changes to the sleep study items following the MBS task force review, and then obviously accounting for a bit of a flattening within the growth of home unattended studies, but a spike following COVID-19 and the pandemic, which we saw as a trend across pretty much all MBS items around the time. Thanks, Marcia. So this slide is interesting in as much as what we're providing here is a bit of an analysis about average services per providers. So we've seen a slow but steady increase in the number of providers, which is the blue line. Services per provider were stable till about 2017-18 and then dropped. And then on average, fewer than 100 services per provider are now billed to Medicare each year. This in of itself doesn't necessarily speak to workforce availability, but it is information that is used by our workforce colleagues in terms of planning, and is also information that we're happy to share with colleges that are looking at potential pathways or how they position themselves for attracting providers to come into the market. You can see for 12250, there's been a more rapid increase in provider numbers, which hasn't slowed down. There was 447 in 2023-24, which you can see on the blue line. And there was a more rapid increase in provider numbers after an initial increase. You can see that the average services per provider has remained relatively stable, which is the red line with a couple of little dips and ups depending upon how you would argue the impact of things such as COVID-19. Key messages would be, from our view, that the decrease in lab-based studies reflects fewer studies on average performed by each provider. Not surprising, the increase in home sleep studies reflects growth in the number of providers, and at a national level, the supply of providers appears adequate to meet the current demand based on what the MBS is telling us around sleep studies. So that is adult. Moving on to Medicare funded items for paediatric. There's 4 items for paediatric sleep studies, the most widely used again being those diagnostic items 12210 and 12213. Notably, there's no paediatric home-based sleep study item at the moment. However, as I mentioned earlier, the ASA has recently provided a submission to MSAC for unattended level 2 sleep studies covering ages 3 to 17 years of age. We can't predicate or predict what the process will be from here, but MSAC is looking at that application, and we have been working with the ASA over the last few months on that submission. So moving on to the next slide. Again, this is just talking about national usage trends for paediatric items. The blue line is those services delivered to 0 to 11 age. Red is for adolescent 12 to 17. Again, not surprisingly from our perspective, many more sleep studies are performed for young children than for adolescents at a rate of about 4 times higher. Compared with adult sleep studies, use of paediatric items for both children and adolescents have seemed to be relatively stable over recent years, again, noting that there was a bit of a dip during the COVID-19 pandemic. And then this slide is just a mirror of what we presented just then for adult, which is a average services per provider. The data basically shows on this table that a relatively small subset of providers, about 40 to 60, perform MBS-funded sleep studies for the 0 to 12 age range, and bill a large number of those services each year. Again, not surprising given they're moving into that specialisation. A large group of providers, about 100 to 170, are involved with the 13 to 17 age group and perform fewer studies each, about 10 per year. So this slide is, I think, as David mentioned, a bit of a 101 as to how we actually make changes to the MBS. So on this is 4 current pathways, and just a reminder that there was a major pathway. So the 2 main mechanisms by which we actually progress changes to the MBS is through the MSAC, which is the Medical Services Advisory Committee. That's an independent advisory committee that receives applications, usually from clinical groups or bodies such as the ASA, for the listing of new health services. It's a robust process. It involves efficacy, quality, and cost effectiveness. So it undertakes an economic review and makes recommendations to government on the listing of services that should attract public funding. MSAC includes clinicians, consumers, health system experts, health economists, and follows an established pathway. It's been in existence now for, I would say, about 30 years almost. And in effect, this is where the applications are considered, recommendations are made to government, and this is where currently the application for paediatric unattended studies is being considered. The other pathway follows the conclusion of the MBS review in 2020 and is relatively new and called the MBS Review Advisory Committee. The key intent of that committee was to set up a way to undertake a continuous review of the MBS. For those that are unaware, the MBS review that looked at all 5,700 plus items of the MBS was the first time that an end-to-end review of the MBS had been undertaken since its inception in 1980s. And basically a key recommendation out of that review was there was a need to develop a process to enable an ongoing review mechanism to be undertaken. The MBS, as I said, is the MRAC is a newer pathway, and there are actual mechanisms for groups or societies to provide requests or identify particular issues of areas that the MRAC should look at. It's also an independent committee that contains a combination of doctors, health system experts, consumers, economists, and operates in a similar way to the MSAC, but as opposed to looking at new services, it will focus more on items that are already listed, whether or not there are unintended consequences and how patient access can be better supported. The other pathways there, which I think are pretty apparent, government obviously and or the minister can trigger a change to the MBS. An example of that was during the COVID pandemic and the introduction of telehealth items, noting that that was extending access in different modalities to patients using existing items across the MBS, but that didn't go through MSAC and didn't go through MRAC. It was a decision of government due to the unique nature of being in the pandemic. Then obviously the department, so I alluded to earlier that there are processes such as post-implementation reviews, which look at the implementation of changes to the MBS usually about 2 years following their implementation, when we have enough MBS data to start informing how they're operating in practice. The department will usually undertake a process of consultation with the sector around those changes. We work with groups such as the ASA, other colleges, clinical experts and the like, and we'll provide government with information based on that entire process around potential policy decisions that government may wish to make relating to the changes to the scheme. And I think everyone on the call is probably aware of the MBS review process. If not, I'm happy to provide that after this meeting. The one thing that I would make clear in the context of this slide is that making changes to the MBS, particularly those that have fiscal impacts, are a decision of government, and there's generally only 2 windows a year in which those decisions are made, which are during the mid-year economic fiscal outlook, which occurs at the end of the year, and at budget, which will occur generally in May, but obviously this year may occur at a different time frame because there's a little thing called a federal election on the radar. Next slide. So this is kind of just a neater way of how we undertake a review or undertake listing of new and amended items. As I said, there will generally be a review or advice that's provided either through the MSAC, the MRAC, government or the department. We undertake a consultation process. We then have to go through that process of fiscal and policy authority. As I said, that usually goes to government as part of the budget or MAEFO process. There's then a process of legislative change that needs to occur. The MBS is a scheme that is covered by regulation, and we need to make regulatory changes in order to facilitate the listing of new services or changes to items on the MBS. We then undertake listing of those items and publish whatever fact sheets and advice would support and help the sector. And also then, as I mentioned, after about 12 to 24 months, we'll undertake a post-implementation review to check that the items are operating as intended. Being a bureaucrat, I can say it's not a quick process. Depends upon the complexity of the change, but generally speaking, it takes probably about 12 to 18 months for an item to go from initial to listing on the MBS. Can be longer, as I said, depending upon the complexity of the changes. So we come here to one of the member questions that was raised as part of the request that we sent out to members. And the question is, can dentists refer patients to sleep physicians for consultation items, which are items 110 and 132? So Section 96 of the Health Insurance Regs specifies who can make a referral and to whom. That is summarised in Explanatory Note GN 616 of the MBS. And in effect, what it says is that all dental practitioners may refer patients to a specialist. That might include an oral and maxillofacial surgeon, for example. However, only approved dental practitioners, i.e. those who are able to claim the items under Category 4 of the MBS, such as OMS specialists, can refer to consultant physicians, noting that sleep medicine specialists are consultant physicians for the purposes of Medicare. So in effect, what that says is that in general, dentists who are not also qualified as an approved dental practitioner for the purposes of Medicare cannot make a direct referral to a consultant physician. But there are a subset of dentists who are able to provide a referral if they qualify as a specialist, and that would count as a specialist to consultant physician referral. We do recognise that specialists and consultant physicians may claim items such as, the sleep physicians may claim items under 110 and 132. One of the observations I do know that Kris is going to cover off is the difference between a 110 and a 132. On the next slide, Marcia, we provide a bit of information. So a 110 and a 116 is a consultation attendance item, and it's important to note that those are broad-based, and these items, though not time-tiered like GP items, are intended to be broad and flexible to discuss with a patient their condition or problem. A 132 and a 133 are for complex planning items with elements covering both the length of consultation but also the requirements associated with those items. Notably, they're not intended to be a proxy for a long consultation, and they're intended for patients with complex multiple comorbidities. It's also important to note for any referring practitioner, in order to determine the appropriateness of a referral for a 132, they should consider the expected contribution of the consultant physician and what they would make in improving the treatment or developing a plan that would help the treatment of the patient according to the complexity of their condition. And in terms of good practice from our perspective, it should be noted that any 132, 133 should consider the patient's usual GP, noting that the patient who's got chronic or multiple conditions may also benefit from chronic disease planning items, which unlock access to allied health and other support services of benefit. We then relate to the member question relating to the item numbers associated with the management of OSA by dental practitioners. The crux of the answer is there are currently no MBS item numbers specifically for OSA management by dental practitioners. Dental practitioners can screen for OSA symptoms and, as I mentioned on the previous slide, in certain circumstances, refer patients to a sleep study or to a sleep medicine specialist or, consultant respiratory physician for assessment. For paediatric and adult diagnostic sleep studies, there's 3 sets of referral requirements. So for the paediatric items, a patient must be referred by a medical practitioner. So that, as I mentioned earlier, is a dental practitioner who's also a licensed medical practitioner who can use that referral pathway. A dental practitioner who is not a medical practitioner may wish to contact the patient's GP to discuss the need for a referral. The same applies for the direct referral pathway to adult diagnostic sleep study items, which also requires referral by a medical practitioner. Pathway 2 for the adult sleep study involves a professional attendance by a qualified adult sleep medicine practitioner or a consultant respiratory physician. As explained in the previous slide, however, only approved dental practitioners or dentists who are also medical practitioners can make a valid referral to a consultant physician. Alternatively, a dental practitioner who's neither of those could contact the patient's usual GP to discuss the need for a referral, or the professional attendance could be billed to Medicare as a non-referred attendance. So we're now heading to the next question, which is, can we bill item number 12250 where a sleep physician wants to test the efficacy of a therapeutic device on his patient who's already been diagnosed with sleep apnea? The short answer to this question is no. 12250 is designed for diagnostic sleep studies only. The item descriptor specifies that it's to confirm the diagnosis of OSA. Once the patient is diagnosed, they're not eligible for a diagnostic study. In addition, a patient can only access this once in a 12-month period. To consider, I suppose, the question more broadly, there's 2 types of lab studies that in some circumstances could be used to assess the efficacy of a therapeutic intervention. So item 12205 provides for a follow-up sleep study in a number of circumstances. However, they are quite specific, and it includes specifically, and there is either clinical evidence of suboptimal response or uncertainty about control of sleep disordered breathing, which may qualify in certain circumstances. So in other words, this item is for the assessment of an intervention that's not working as expected. It's not for routine evaluation of the treatment success. And then there's also item 12204 that allows for overnight assessment of a therapeutic intervention, but is available only for positive airway pressure therapy. Thanks, Marcia. So this is, as I promised at the beginning, where can you find more information on MBS claiming? So there's a couple of different places I direct you to. So firstly, there's a great HW publication on the profile of people who are undertaking sleep studies in the treatment for sleep disorders. That's since 2001, but it is an interesting data source on one which we keep across. The other data source that is of interest to people might be the Medicare statistics reports, and I'm happy to circulate those subsequent to the meeting, the links that are hyperlinked, although I probably suspect that our presentation, I'm more than happy for that to be shared with members in a format where they can just click on it. But that's through Services Australia, and it provides the raw data that we used for today's presentation in providing those graphs for you for information. And then the next slide is handing over to Kris to talk about sleep study compliance. Thanks.
Thanks, Steve. Can everybody hear me to start with?
Yes, thanks, Kris.
Thanks, Dan. Okay, so look, Steve's giving you a comprehensive look at what they look sleep studies about, so I'm not going to go over that again. I'll just say what we do. Ultimately, we want to make sure that everybody's doing the right thing. We want to help people access Medicare, the community, and we want to allow people who are using the Medicare to, in their profession, to do the right thing with education and support. So we'll start with health provider compliance, which you've got up there. The department is responsible for ensuring compliant health provider claiming under Medicare benefit schedule and the PBS and the Child Dental Benefit Scheme. We do this through identification, prevention, and treatment. And this could be through incorrect claiming, prescribing, or supply of medication. And we could detect this through and act upon by inappropriate practice, and also fraud by healthcare providers and support staff. We'll talk about that later, about support staff. Our response to compliance issues is proportionate, prioritized, based on the seriousness and the scale of identified issue. The compliance program seeks to support providers to get it right, increase compliance with claiming requirements. Just going to turn this volume down, and take compliance action to support a sustainable and affordable health system. Can we move to the next slide, please? Thank you. So the compliance approach, you may have seen a pyramid before, but this is a new pyramid that we've got. It's going to be approved, or seeking approval from the secretary, and hopefully it'll be published in early next week. And it's about our compliance approach and what we are seeking to address. Compliance functions such as ours use a pyramid to demonstrate the range of compliance responses or treatments that we use. We use a variety of treatment approaches, including education, letters, audits, and professional review. And ultimately, it may lead to investigations if we find fraud or possible concern about fraud. Our response to compliance issues is proportionate, prioritized, based on the seriousness and scale of the identified issue, as I said before. By ensuring accurate health payments, we support the sustainability of the health system. The department compliance model ensures that we deploy resources appropriately and in a way that is proportionate to the resources that's available and seriousness and scale of the identified concern. Sometimes we could treat a risk through multiple compliance treatments. Depending on the risk, we may choose to do education as well as other compliance activities such as audit or practitioner review program. Where apparent non-compliant behavior continues, we may elect to escalate to a higher level treatment after education or nudge letters, as we talk about. Most importantly, all of our compliance activities involve an opportunity for practitioners to self-reflect and provide us with further information. We do not just make decisions on data alone. And the department is currently updating its health provider compliance strategy, and it'll be available early 2025. Next slide, please. So, as you can see, at the bottom of the pyramid is education, but it's not by any means the least form of compliance treatment. We want, as I said, support and provide education to providers to do the right thing. And we also want to engage and consult with them in how to go about it in achieving future compliance. Education support offerings are being expanded across multiple platforms and services, including Ask MBS, e-learning, online resources, and advisories. Ask MBS is a very good source of accessing information. It is the turnaround for them is about 8 days on average. 90% are turned around within 15 days. The more information you provide regarding a specific query, the sooner and more accurately they'll be able to respond to you. Next slide, please. And then we have the letters. We also use letter campaigns to educate providers where we identify a certain pattern or trend in claiming which does not look consistent with the MBS requirements. In this case, we ask the provider to self-assess their claiming and to voluntarily pay back money that they may be not entitled to. Concerns about approval, billing, or claiming by a provider may also be addressed through letter campaigns. Early intervention provides us with information and also the provider with information on correct claiming, while offering practitioners the opportunity to self-assess. And this behavior change obviously would, hopefully, lessen the likelihood of future interventions such as audits or practitioner review program. Audits are when we suspect there's a legislative breach has occurred or the item has not been met from the descriptor requirements. And the aim is to establish whether health benefits have been correctly claimed, includes assessment and verification of information obtained by the department and through interactions with the health practitioners. So you'll get an opportunity to provide information to substantiate the services that you have billed to Medicare. Next slide, please. Practitioner review program is a peer review process. Again, if we detect that there have been services billed that may not have met item requirements or services that may not have been clinically relevant, then we interview the practitioner to see what response they have to give to us to substantiate their billing, which may be different to their peers. Clinically relevant services is one such would be regarded as by the peers or a panel of peers as relevant for treatment of a medical condition. And where the concerns are not resolved under PRP, a request may be made to Director of Professional Services Review, who can review your clinical records to see what you have billed can be substantiated by what you have done and recorded as clinical records. Bearing in mind that clinical records have to be adequate and contemporaneous. Next slide, please. Towards the top of the pyramid, we've got the fraud investigations. Fraud against the Commonwealth is a criminal offence. A person may be investigated if they're suspected of intentionally obtaining or attempting to obtain health payment by deception. Investigation may result in criminal prosecution. Any decision to prosecute is made by the Commonwealth Director of Public Prosecutions. For some of the statutory offences are prohibited practices in relation to pathology and diagnostic imaging, Pharmaceutical Services Federal Committee of Inquiry, and public hospital compliance, where duplicate payments may have been made to Medicare and also from the public hospital funding as well. While we have a variety of mechanisms to respond to potential non-compliance, our preferred method is to achieve compliance through supporting practitioners, healthcare organisations and peak bodies to correctly claim health payments in the first instance through education, engagement and consultation, which is what we're doing today. Next slide, please. So how do we identify non-compliance? You wouldn't believe it that we receive a lot of tip-offs now. People are quite savvy, computer savvy, and they are able to access MyGov and look what items have been billed or items they've been prescribed. And they come back to us with tip-offs saying that I saw so-and-so and I don't think I saw him long enough for this item to be billed, or I didn't have the service completed, but yet I noticed in my billing or on my profile, there's an item that I never had. So we get quite a lot of those tip-offs. We also get tip-offs from other agencies and stakeholders, but also from your other colleagues, health professionals, who may detect there is something going on that's probably not, it's not holding up the integrity of Medicare or the PBS, and they may be wanting to do the right thing and send us a tip-off, anonymous or actually not anonymous. But we always treat everything with the privacy provisions provided to providers, tip-off people. So there's nothing to really worry about to give us your name and details if you are wanting to do a tip-off and want to keep the privacy secret. We use targeted data analysis and intelligent collection. So we routinely analyze data to see if there's any outliers of any provided services. And again, we continue to engage with stakeholders, and this which has helped us to better understand the nature of the concern and any environmental factors that might be relevant. For example, during the COVID pandemic, we saw sleep studies go down, and soon afterwards, we saw it rise at a rapid rate, probably because a lot of people hadn't had their sleep studies and were waiting. And that's a simple example. Our detection techniques are always validated through human analysis, so it's not just machines and algorithms. Health professionals such as me look at the data, and compliance officers and other subject matter experts as well. As I said, there's a code at the bottom of the slide there. You can scan this code, and that will direct you to an online form for you to make a tip-off if you wanted to, or anybody wanted to. Next slide, please. So when a practitioner bulk bills a service, the practitioner undertakes to accept the relevant Medicare benefit as the full payment of the service. So, for example, if you were to do skin lesion excisions, or in your case, were to do a service for respiratory physicians doing spirometry or other services that may require other resources, they cannot bill that separately if you bulk bill the patient. Any consumables or any other material that you use cannot be included if you are bulk billing, and you cannot bill them separately. And you also have to bear in mind that charging extra not only breaches the legislation, it skews the data on services and hide the real cost of healthcare from the public and policymakers. So a service that is bulk billed should be regarded as a full payment for the service. So next slide, please. So as Steve mentioned before, we talk about 132 and 133. These are supposed to be provided by a consultant physician for patient diagnosed with multiple morbidities, including complex congenital, developmental, and behavioral disorders. These items are particularly relevant for management of patients with complex sleep-related conditions. Adherence to the specific requirements of these services items is crucial for compliance. Now, when we say about multiple comorbidities, it may be that sort of two are required in order to be eligible. However, the sleep physician has to address those two comorbidities in their management plan in order to be able to bill that. So the intent of the item 132 is to develop treatment and management plan for the referring practitioner. The department is currently reviewing sector claiming of MBS items 132 and 133, and we will consult with the ASA in the coming weeks regarding those two items and their review. The review considers identified behaviors such as high servicing, routine claiming of a new plan, and claiming a repeat plan in a review that's a review plan as item 133 in a short time frame. These claiming behaviors may indicate that the full item descriptor requirements have not been met. Next slide, please. So 132 and 133, let's talk about this a bit more in detail. The minimum requirement for item 132 is 45 minutes. Now, this requires that you take a detailed history of the patient's condition, and they must at least have two comorbidities, as I mentioned before. Comprehensive assessment and a management plan. The comprehensive documentation must include a detailed history, examination, diagnosis, and management plan that is provided in writing to the referring practitioner. If a provider is using 132 for cases that do not meet the complexity threshold or the time, and also fail to develop a proper management plan, that's not compliant. And the time periods that are required are item 132, 45 minutes, and 133, 20 minutes. It's a common course of audit and also practitioner review. because we can actually see how many are being done in a day, and it doesn't usually match up with the amount of time the practitioner is working. So rendering these items for initial and subsequent consultation should not be done in a hospital environment. They're meant for outpatient settings. And providers are routinely billing these items hospital patients. They may be audited for incorrect claiming of MBS benefits. So the item 132, what we quite often see is followed up by an item 133 within a couple of days or even a week of the initial management plan. This brings to the question of, has the patient had enough time to act on the management plan? Has the practitioner who referred the patient has had enough time to instill the management plan's requirements? Has it been an adequate time for it to all work? Otherwise, it's a pointless exercise reviewing the item 132 in a couple of days. And we routinely look at that pattern as well when we do compliance activities. So just to summarize, we need accurate documentation. Next slide, please. Yeah, so accurate documentation is important, as I said. Make sure you thoroughly document everything, detailing the patient's history, examination findings, diagnosis, and the management strategies. Time requirements, again, 45 minutes for the 132 and 20 minutes for the 133. You'll do well to document those times in your notes so that if you are audited, you have that time written down. Just bear in mind that you cannot claim item 110, 116, and 119 on the same day as a 132 or a 133. Make sure the patient eligibility criteria, including having 2 comorbidities and a valid referral. As I mentioned before, it's not just that they have 2 comorbidities. You have to address them in your management strategy. Otherwise, it's not a clinically relevant service. Okay, so moving on to more information about item 133. You can claim item 133 a couple of times a year, but it's not required unless there's been a change in the patient's condition. 132, which is the initial plan, can be billed every 12 months. However, you will need a referral from the referring practitioner. And unless the condition has changed or the patient's situation has changed, you should really not have to bill another 132. So bear in mind that we can actually see when there's a pattern emerging that a patient is getting a 132 on every 12 months on the clock. We can see that's happening, and we may ask you for explanation. Okay, next slide, please. So one of the questions that we had from an ASN member, do the overseas requirements include both reporting and billing of a sleep study or only billing? This concern relates to providing MBS services while overseas by a provider. Section 10 of the Health Insurance Act states that the Medicare benefits are only payable for services rendered in Australia to an eligible person. The department's long-standing position and advises that both the rendering practitioner and patients must be in Australia for the service to be eligible for Medicare benefits. Analysis for this involves data matching movement records from Department of Home Affairs to MBS claiming data. And a variety of MBS items and provider groups have been identified. Providers who were selected for compliance were subject to an audit or letter sent to self-assess their claiming. And we're continuing to monitor this type of claiming. Next slide, please. Just go back to what I was talking about, the overseas claiming for respiratory physicians and sleep studies. So if one is overseas when the patient has the sleep study and the sleep physician returns to Australia and reports it, it may be that it shows up on our data that the sleep physician was overseas when the item or the service was billed. However, we will give an opportunity for the sleep physician to explain the situation, noting that also all components of the item needs to be fulfilled before it can be billed to Medicare. There may be some questions later on. What I can say is that if you have any more questions about overseas claiming, or if you're confused about date of service falling on the date that the rendering provider appears to be overseas, suggest you contact Ask MBS to explain what's going on and what you can do about it and how you can prevent that situation occurring again. So next, common sense compliance. As I said before, make sure all services are clinically relevant. Explain to you what clinically relevant was. And if you don't know what an item descriptor or an item's full descriptor is, do not bill it. It's your provider number. Make sure that any item that's billed by you or on your behalf by a delegate meets all the requirements. And if you're not happy with the requirements that are being met, then do not bill that item. And remember, all MBS items are complete medical service. This means that any task that would be considered integral to a particular service would not be claimed separately under another MBS item. Encourage you to apply your own fraud control measures. We're seeing more and more of staff members committing fraud, especially with workforce shortage at the moment. We've noticed that companies and practices are employing staff they may not have had a chance to check their prior history, criminal history, police check, etc. And we sometimes even note that the repeat offender is moving from one practice to another to commit more fraud. Implement good administrative services, administrative and clinical record keeping, and promote these values when inducting new staff. And regularly check and review your list of delegate staff who manage your claims. Your provider number can be temporarily stopped from claiming MBS services if you are traveling overseas. So that's another option to make sure that nobody else is billing under your provider number when you're overseas. Next slide, please. Probably wondering why I'm coming along to this with semaglutide. I work for the Defence Force as a medical officer there. Noticed that more and more patients are now becoming overweight and as a result suffering from obstructive sleep apnea. And we're referring more and more patients to sleep physicians for sleep studies. What we want to make sure that any prescriptions for semaglutide or Ozempic, the trade name, is only written for treatment of type 2 diabetes. We recently had a practice fined $300,000 for unlawfully advertising weight loss medicines, including Ozempic. It can be prescribed off-label, but bear in mind that there are other alternatives such as Wegovy and Mounjaro, which are approved by TGA for weight loss. And also it stops a shortage occurring again for Ozempic, which is actually put aside for diabetes. And also we noticed that prescribing semaglutide or Ozempic and the shortage allowed scams where there were labs made up in garages that were making up semaglutide and selling to patients. Next slide, please. So one can't assume that because you were paid for a service when you submit a claim, does not mean that service is compliant. Most claims are processed and paid automatically based on the information submitted. This means SA systems assume the details provided by the doctor are correct at face value. However, as we discussed already, we regularly conduct compliance detection checks, data matching, followed by activities such as audits or to ensure that claims are according to the MBS rules and the legislation. In short, payment does not equal compliance. A claim is only considered truly compliant if it meets all MBS requirements and passes any potential compliance reviews. Next slide, please. So we understand that some ASA members have expressed concern that the Ask MBS information implies a very literal and inflexible interpretation of clinical guidelines. And we also want to make sure that you understand that if you provide information in your clinical records why you've had to deviate from the requirement, such as a lead cannot be placed on a missing limb, or there's a wound there, or there's a patch of hair that's not able to, that your lead cannot be applied to, make sure you document that in your records. Or that way, if we were to audit or do a practitioner review program on your provision of services, we have information to substantiate why that the actual information was not available when we look at the reports. We've also made some changes to the explanatory notes associated with these items to confirm the current professional guidelines that apply for MBS-funded investigations for sleep disorders and the relevant part of these guidelines that are required to be followed. So as you know, as Steve mentioned, 12203 to 12208 is for level 1 adult sleep study undertaken in sleep laboratory. 12210, 12217 is for pediatric sleep study conducted in a sleep laboratory, and the 12250 is a level 2 adult sleep study that is undertaken outside a sleep laboratory. So moving on to the next slide. The next question was, I do sleep study reporting for a sleep unit in a public hospital. I do not have clear idea of what sleep study claims have been made against my provider number. Please advise how I can check what claims have been made to ensure my provider number is being appropriately. This is an interesting question that I get asked all the time, not only by your respiratory physician, but also by all specialities, including general practice. It's actually important that you come to an agreement with the biller or the hospital or the practice that you get a detailed summary of your billings at the end of every week or otherwise every fortnight. And you need to check on that and sign it off. Signing at the bottom of the paper, bottom of the document doesn't really allow you to scrutinize what items have been billed under your provider number. So it's very important that you have that information on a regular basis so that you can do a self-audit yourself, because bearing in mind you're responsible for your provider number. Approach the hospital administration and request a summary of claims made to that date or a given period And if they don't want to do that, well, there's a problem in the first instance because they're obviously not complying with your contract, or they're trying to hide something from you. But failing that, you can always contact Service Australia and make inquiries of either the e-business service centre or the Medicare provider inquiries. There's a QR code there. If you want to scan that, you can get those to line of inquiry. Just remember, all these slides are going to be available for you through ASA. So hopefully you'll be able to use those QR codes that have been through the slides and make use of them as required. Compliance priorities. Next slide, please. So, as I mentioned before, our compliance priorities in 2025 are being finalised. So, as I mentioned already, bulk billing is at the top. We really want to make sure that there's access to affordable healthcare for all Australians. As you're aware, when a health professional chooses to bulk bill a service, they accept the relevant Medicare benefits, full payment for the service. Charging a co-payment or membership fee is breach of the Health Insurance Act 1973. We find that a health professional has charged co-payment or a membership fee after a bulk bill service, then we will be looking at that in very detail to ask you for an explanation. Specialist and consultant physician claiming of attendance items and management plans. Now, these have been the largest contributor to Medicare benefit schedule expenditure. Our data shows specialist and consultant physician attendance items drove the growth of attendance services in financial year 2023 and 24. And this includes items 132 and 133. And they are increasing in numbers. And we are certainly wanting to look at how to educate and also make sure providers are billing them when necessary and when relevant and meeting all the item requirements. And we want to make sure that you're doing the right thing. We want to make sure that the services that are paid for are going into the right people for the right service. And this will protect the sustainability of Medicare for years to come. MBS billing whilst overseas. We've already talked about that. However, again, we'll be continuing to look at that. And just bear in mind, they have to be performed in Australia to an eligible patient. Then we have duplicate payments. So this is regarding hospitals where MBS billing is also occurring as well as accessing hospital funding. And that's called duplicate payments, and it's actually a breach of the Health Insurance Act also, Section 19. So you're actually in Commonwealth funds as well as state funds, and that's not compliant. Again, this will lead to sustainability of Australia's healthcare system. And yes, we know that there's a lot of doctors asking for, hospitals are asking for referrals to GPs. Well, you need to question why, and are their patients electing to go private or remaining public? And I think it's important that you determine what the hospital billing service is doing on your provider number in order that you don't have to repay money back to the Commonwealth. And then there's the opportunistic billing and emerging business models. So there's always been a case of maximizing revenue. I understand it's a business, and revenue generation is important in order for survival. However, patient care is also so important, and the services have to be clinically relevant. And it's your duty of care to make sure the patient has adequate treatment and only the treatment that's necessary to avoid complications. The integrity of the Australian government health program payment is impacted where arrangements between an organisation and the health provider remove health provider control over their claiming. So this is where an organization says, we'll take care of your billing, you look after the patients. Doesn't quite work like that, because if the organization decides to go rogue and bill on your behalf inappropriately, you're held accountable. The practitioner's clinical independence is undermined by corporate billing sometimes, and this is again another red flag that you need to bear in mind. High cost PBS medicine. We look at pharmacists as well for claiming for high cost PBS medicine that may not have been prescribed or clinically needed, and also claimed without a prescription. So we do look at pharmacists as well, and we make sure that we audit them and take them to task if we detect anything inappropriate being conducted. Suspected fraud. We continue to improve our advanced analytical model to detect fraud, and are committed to tackling illegal activity and behavior of concern to protect the integrity of Medicare. So you can also access the Medicare Provider Handbook, which is was launched earlier this year, or late last year, I should say. This gives you a clear guidance on all essential topics: Medicare programs, Medicare and hospitals, Medicare safety nets, Medicare benefit schedule rules and requirements, Medicare claiming, Medicare benefits, where to get help and support. Again, there's a QR code there. You can download it and have a copy. And this is actually a very good source of information, whether you're an experienced practitioner who's been using Medicare for decades or a newcomer to the Medicare system. Next slide, please. What do you do if you make a mistake? Now, voluntary acknowledgement of incorrect payments. One of the questions that I get asked always is, if we do a voluntary acknowledgement of incorrect payments, do I automatically get targeted for further compliance activities? Firstly, no. And secondly, we look at that as a practitioner conducting his own review and an audit of their services, and proactive in making sure they're doing the right thing. So it's actually a tick from me if somebody is voluntarily acknowledging incorrect payments. It's very important that you let us know as soon as you can before we identify incorrect claiming and then approach you. Just bear in mind also, there's no penalty if you submit a voluntary acknowledgement of incorrect payment. However, if we were to audit you and then we raise a debt, there will be an admin penalty also. So it's in your interest to do a voluntary acknowledgement if you detect any incorrect billing, to avoid admin penalties that may be applied if we were to detect non-compliance. Once you've supplied the voluntary acknowledgement, we will calculate and send you a bill telling you how much you have to repay and the ways you can repay it depending on how much it is. Next slide, please. So who can I contact if I have an inquiry? Look, we talked about Ask MBS already. I think any specific questions that you have, the more specific information that you provide around the scenario, the more accurately they'll be able to respond, and quickly they'll be able to respond. We do not, just because somebody talks to Ask MBS, we do not automatically target them for compliance activity ourselves. In fact, we do not link compliance with Ask MBS. So you can do that with trust and security and ask any questions you want. Health compliance education, also, who is providing this webinar today, will be able to also assist you with any inquiries that you have. Look, thank you very much. Look, I could talk about compliance and various scenarios forever. However, there are questions that I'm sure you have that you may want to ask. As I said, you can always write to us and we'll be able to respond in writing and it'll be accurate. Also, compliance is not about nasty people trying to make you feel bad. We're trying to help you. We're trying to assist you do the right thing. We also want to make sure the integrity of Medicare is is sustainable, and also want to make sure that new services can be provided if we were to bill correctly on all occasions. That's all from me.
Yeah, thank you very much, Kris and Steve. And thanks very much for that presentation. Steve's been doing a great job fielding questions in the Q&A box. Thank you very much, Steve, for doing that. So then just a follow-up question, Kris, one of the sort of pre-seminar or pre-webinar questions we'd had from one of the members is what would define an outlier in terms of triggering an audit, for example, for sleep study reporting?
Yeah, so that's an interesting question. And we always look at outliers, and we not only look at the outlier that is maybe 20 or 30 or maybe even 50% more than the number 2 ranked provider, but we also look at reasons why there may be an outlier. And I think what people have to bear in mind is that we do not rely just on data alone. We will actually be asking a provider, you are an outlier, and we'd like to understand why this is occurring. Now, one may have a very reasonable response to that, or may not have a reasonable response, or may not even know that they were an outlier, and we'll be giving them an opportunity to reflect on that and change their practice in a way that they're not an outlier anymore. Answer to your question, look, it doesn't really matter. An outlier can be just 10% out from everybody else, or they could be a lot further out. So, and we don't always just look at outliers. We may be just looking at the top 1% of providers. Even they could be outliers. So when you ask about outliers, obviously they'd have to be very much out as an outlier in order for us to target them in a risk. However, as I said, an explanation is what we're after. We want to make sure that we're not just relying on data. We want to make sure that we want to hear the explanation that the practitioner has for that.
Yeah, and is there somewhere where providers can see where they might sit on a centile chart? So Steve told us about a site where we could see total numbers of performances and potentially services per provider. But as an individual provider, could I see where I sit on a centile chart?
Look, I'd have to take that on notice, and I think we may be able to help you with that. If you write to compliance, education, we may need to get back to you on that.
Just as a clarification, when I presented that information on where to access the data, that isn't data that's provided by individual providers. It's data that relates to the utilisation of an MBS item. So that level of granularity would not be generally available through Medicare. We'd have significant privacy concerns if we were to ever release that data without provider consent.
Thank you. So a theme that's come up in the questions is about the overseas and I think it's pretty clear. Thank you that you've helped us understand that the provider shouldn't be reporting a sleep study when they're overseas. But there are other parts of that process, like data collection done by the sleep technologists, billing done by the office. If those are done when the provider's overseas, is that in compliance with the legislation?
Correct. So all aspects can be done while the provider is overseas. However, the reporting has to be done once the provider is back. The claim date needs to be the date of service, needs to be the date that the patient stayed overnight, and needs to be the morning of the patient being discharged after the sleep study. But the date of service is when the patient occurred, and one cannot change that. However, when the data shows that the sleep physician was overseas, and we ask a question, the sleep physician will have the opportunity to provide an explanation. So it's only the reporting that needs to be done once the provider is in the country. And even though it shows that the claim date might have been when the provider was overseas, if one provides an explanation and evidence that they did the reporting whilst they were in the country, by the report date reflecting that they were in the country, then it should be fine if we do audits and any letter writing campaigns.
Yeah, thank you. And another theme that's come up in the chat box is just the sequencing potentially of 132, and is that always must be followed by a 133? Can you follow a 110 with a 133? Can you just talk through a little bit of that sequencing?
Sure, I can do that. What we're noticing is that people are routinely using 132 as an attendance item. Okay, that's not what it's intended to be for. So people realize, or consultant physicians have noticed, that the 132 pays a lot more money than the 110. So they're automatically choosing a management plan and using that instead. That is not what it's intended for. So if one bills a 110 for the first consultation, and the patient comes back another time, and then you decide that they have at least 2 comorbidities, and the management plan would be beneficial for the patient's management. And then if we provide that information to the referrer, hopefully a GP, they'll be able to enact that management plan and make the patient continue on that management plan. Now, it would be a good idea for the patient to be reviewed in order to ensure that the management plan is working, but it's not absolutely necessary. It has to be clinically relevant service again. It needs to be required unless it's pointless. As I said before, what we're noticing is that a 132 is occurring on the first appointment with the specialist, consultant specialist, and then a week later, they're getting reviewed for the 133, and that doesn't really seem to have an opportunity for the patient or the GP to act on the management plan that's been provided. It's almost 110 or 116 has been replaced by 132 and a 133. Now, if we were to look at the clinical records, it would possibly not be clinical relevant services, or may not have met item requirements. So we're really trying to stamp down on that to make sure with education that people realize what the intended idea was between the 132 and 133. And the 110 is still there for the initial consult. You can always go on to bill 132 later on in the time the patient continues to see you. It doesn't have to be the first time or not at all. And we're also noticing that the 132 is occurring 12 months after. Now, as you know, if it's a continued condition that's being managed by a consultant physician, unless a new condition has arisen that needs to be addressed, one can only bill a 116 the second time on the review, even 12 months later, with a new referral, because it's the same condition, but with a new referral. What we're noticing is that when the new referral comes in, people are automatically doing another 132, even if the condition hasn't changed. So again, bear in mind, these services are for the benefit of the patient. If it's not improving the condition of the patient in any way, then it's not a relevant service. And only a panel of peers can decide that as not relevant. So bear in mind, each time you bill an item, is this item, this service, going to benefit the patient's condition? And I think not only is the practitioner may not be looking at that, but also the business influence is there as well. Again, there's disconnect between good clinical practice and good business practice. And I think that's where we need to meet in the middle and question what is being billed on our provider number.
Okay. Yeah, thank you, Kris. And just Steve, changing tack a little bit, just to finish up, there's a question about Medicare's role in assessing new technology. So the way this is potentially relevant for item 12250 is it was approved in sort of 2011 as a a well-defined level 2 sleep study. And with changes in technology over time, there are changes, but at what stage is there sort of, not creep isn't right, but evolution within an item number versus needing an application for a new item number? You don't need to be specific about that, but just in a general sense.
Sorry, David, about halfway through that I dropped out, but I think I
No problem.
the gist of your question. So I guess there's a few observations I'd make, and I think some of it relates to some of the other commentary that I've seen in the chat from today's webinar. Firstly, it's important to note the difference between an explanatory note and an item descriptor. An item descriptor outlines mandated requirements of what must be met in order for a Medicare item to be claimable through the MBS. The point of an explanatory note is to provide relevant guidance to providers in how to appropriately deliver those services, either in accordance with clinical guidelines or with guidance. The department doesn't set that guidance, and it's important to note that the MBS is a payment scheme, not a driver of clinical practice. We try to reflect contemporary clinical practice, but we don't operate as a driver. In terms of changes to the MBS and item descriptors, generally speaking, when we are talking about a new population, where we're talking about the expansion of a service to include new elements that are actually related to delivery of the service, and certainly in situations where it will have a material impact either to the population of people or to the fiscal, i.e. the fee of a service, is the situation where we would undertake appropriate assessment pathways versus per that slide, which I provided as part of my presentation. I do know as part of some of the questions today, people have been saying, why isn't this talking about the 12250? I guess the message from an MBS point of view is we don't dictate the clinical guidelines or pathways. We work collaboratively with groups like the ASA. We do work in terms of making sure that we understand from a compliance point of view that the service is meeting the intent which has been agreed by MSAC or recommended or agreed by government. But generally speaking, if there are non-material changes or there are changes that are talking more about the quality of a service and how a service is being delivered to best meet the needs of patients, that is stuff that we will include within the explanatory notes to help provide that guidance. If it is something that we agree or government agrees is a mandated requirement, i.e. This must happen in order for this service to be eligible, at that point, it would go in the item descriptor, which is the enforceable component.
Yeah, thanks for that, Steve. And I think some of the theme is, maybe people suspect there's been some change in the requirements for 12250. In fact, there's been no change.
There's been zero
And
change in the requirements.
the explanatory note really has just been to highlight exactly what you've talked about, that as long as it's performed in accordance with guidelines, as the person who's been involved in helping develop the guidelines, what we've got to be cognizant of is to change a guideline, there's got to be peer-reviewed evidence to support changing a guideline. And that results in an inevitable delay between maybe a new technology evolving, that evidence base being developed to be able to update a guideline.
Yeah, correct. We talk with a range of different provider groups in updating any of our explanatory note guidance to help people understand how they provide an MBS service in accordance. But you're exactly right. There's been no material change to the actual requirements under 12250. Those requirements that are contained within that item descriptor remain the same. Where explanatory notes can be particularly helpful, and Kris can offer some observations if you'd like, is often that's useful for the body of peers example of them to actually understand what was meant when we created that item. What was the intent of that item? What did we expect the quality processes that underpin how that item is delivered? Is where you would get a group of people together to say, did this actually meet the intent of what the MBS claim was meant to be about?
Yeah, and that was one feature of the explanatory note, was also outlining that MSAC didn't approve level 3 and level 4 sleep studies so even though it's an unattended sleep study, it is a level 2 sleep study and all that encompasses, rather than a simpler sleep study. And it's been a bit confusing. In the United States, there's a term called HSAT, home sleep apnea testing, and that term in the US at least encompasses some level 3 sleep studies, and that terminology sometimes leaks over and has caused a bit of confusion.
And it's, as I said, it's also worth noting that there are existing pathways for people to make applications for any new service or item to be listed on the MBS. I'm not trying to predict what MSAC would say in respect to that, but there are evidence requirements around the cost effectiveness, quality and safety and value of a service that the government would consider listing on Medicare. But that does not mean that there's no open pathway for such applications to be put forward in future.
Yeah, thank you. I'll finish up. I'll just answer one of the questions in the chat box, which is more relevant from me from a clinical sense. It was about the consensus on gender-based questions for the OSA 50 and stop bang. And we discussed that at the clinical committee and felt that on an individual basis, the practitioner should really decide either what gender that they think that individual fits best to be categorised as, or to use the Berlin questionnaire, which doesn't have a gender requirement to it. All right. Thank you very much, Steve and Kris. And I'll hand back to you, Marcia, just to close up.
Thanks, David. And thanks, David, for your chairing of the session as well. And thank you from me to Steve and Kris and all of the people behind the scenes who've helped prepare this webinar as well. Thank you for coming, everybody, and for all your questions. We'll do our best to kind of keep the information flow coming to answer questions that we didn't get a chance to answer. I'll send everyone an email when the video is available, and we'll circulate the PowerPoint slides as well. And feel free to get in touch with me if you want to follow anything up along the way. We've got some great things coming. If you're in New South Wales, we have our state meeting at Westmead on the 3rd of April. And then we've got 2 great webinars coming up, sleep health equity on the 15th of March and oral appliances, severe OSA and endotyping on the 9th of April. So put your registrations in for those, and they're all free if you're an ASA member. Thanks again for coming, and hope to see you again soon. Thank you.